it's really helpful for us to have a chat about how primary care can respond to the initiative within the Perfective project, and think in terms of how primary care can fulfill its responsibilities once we start to get the care we need to in a secondary care environment. But I think to do that in the absence of the really quite seismic changes that are taking place in health and social care would be unwise, because we are at a time when the whole system is really changing quite dramatically. People talked about the 5-year plan. Norman Lamb was mentioning it earlier. And the old world of primary care and secondary care is something which I would suggest you remember, because it's not going to be around for very, very much longer, thank God. The old world of healthcare and the biomedical model being fundamentally different to the world of social care and what people consider to be important for them is something which perhaps is not going to exist forever. The world where primary care is responsible for commissioning and secondary care is responsible for providing, and these bizarre divisions that we have instituted into the system may not necessarily be something which will survive. We are in a world where we're running out of money, and that is probably the best thing that could ever happen to us, because that's the only way in which we're going to change a system which has been and continued to develop in a way which has been completely independent. We are looking towards integrated care in the future. Everyone's talking about integrated care, whatever that means. Everyone's talking about people working together and loss of fragmentation, whatever that means. But in essence, where we're going to is a place where we all will be responsible for commissioning, where we all will be responsible for providing. And really the whole system then starts to change really quite dramatically, because at the moment what we have is primary care that sees itself as delivering part of a service. In bits, it even denies it has responsibility around delivering that service. In other bits, it's really overwhelmed with trying to deliver the service. As, again, Norman Lamb said, there is incredible inequity in the way that service is delivered. We have secondary care, which where the rate of underdiagnosis in terms of dementia and dementing illnesses is significant, where medicine by body part is practiced to a degree which surpasses what we do in primary care, and that's saying something, because we're really experts at medicine by body part. And, you know, we have this unstable mix, and we really need to think beyond it. At the moment, we have commissioners who think in terms of commissioning services as long as they are in the way they have always been commissioned, which basically does nothing other than perpetuate the really quite dysfunctional ways of being working. We have hospitals which deliver services based upon payment by results. Quite appropriately, what they have to do is deliver financial balance, and it's getting more difficult for them to do that with the increasing pressures of multimorbidity, increased aging, and everything else. And clearly, this thing isn't working. So instead of saying why the system isn't working, because I think enough people have said that, let me just spend a couple of minutes talking about how it could work better, because it really could work better. Part of my world is within Public Health England, where I'm very active at trying to foster concepts around risk reduction in dementia. And by risk reduction, I don't mean one can completely prevent a condition, because one can't. But what I do mean is that there is a significant component to dementia which is amenable to delay. And that delay and that compression can be quite significant. As Jeremy said before, when Jeremy Hughes from the Alzheimer's Society, the medical profession has been very good at extending life, but not that good at adding life to years. And if you ask me how I want to die aged 105 suddenly. So I'm looking to you, Chris, to shoot me at 105. Because then my decline, I hope, will be sudden. And that suddenness of decline clearly is something which we all want, to live as fulfilled a life as possible. Now, if we start thinking about our own responsibilities around managing our own risk factors from early on, and that's where primary care is so important. And by primary care, by the way, I do not for a second mean general practice on its own. I mean the whole of primary care, community pharmacy, which is one of the most underutilized resources in England, and the social world, care workers, local government, everything else associated with that. We all have a role to play here in ensuring we understand our risks and can make reasoned judgments as to what we think we should be doing to actually manage our risks better. And that's what I see the role of primary care in the new world, which you will assist in terms of getting secondary care to a place where it works better. And if we then think around primary care in cases making diagnosis of dementia, when it's obvious this is a dementia, especially in somebody who fits a pattern in older age groups, for example, where anybody can make the diagnosis, where the differences between the different types of dementia may be less relevant. There are cases which will always require the input of memory clinics, and I am not suggesting that we ditch memory clinics before I'm accused of saying that, because I think we need both. We need a primary care that's active at case finding and looking for people who are at risk of developing dementia, i.e. people with diabetes, people with hypertension, people who smoke a lot. All these cases can actually be managed by us ensuring we message people correctly around what their risks are, and then being given the opportunity to make a judgment as to how they wish to decrease that risk if that's what they wish to do. And also primary care taking some responsibility around the post-diagnosis support, because at the moment there is a view, certainly within some people within primary care, that all we need to do is identify and refer. That is a pretty old-fashioned way of working. We need to make dementia very similar to what cancer is now, where it's understood to be a condition where a lot of people have input into the care of the individuals, rather than this is solely the remit of one specialist rather than another. And we also then need to start to work around secondary care to get away from the medicine by body part, as I said. And when people leave hospital, to ensure that we start to do some work around end-of-life care, which I suggest we really have some significant amount of work to do, because people are not involved in that care as much as they should be, or early enough, as well as enabling people to make the right choices at an early enough time and involving carers. But to a degree, that's all motherhood and apple pie, isn't it? And the question is, how does one achieve that? And I think there are ways one achieves that, and the ways one achieves that perhaps is instituting new metrics, new systems of payment, which encourage a completely different way of working to the ways of working we have at the moment. So move away from the payment by activity, which is really what payment by results is, to different systems for secondary care, and also different systems of primary care, to really think about a metric which actually unites the two bits of the biomedical model with the social care model. And that, I think, is the future that we need to see to make the perfected project really, really sing. I think that's really about all I want to say, because I want to give people an opportunity to ask a few questions, to have, to give their observations as to whether this is crazy or otherwise, because I think it really will work, and I think it's the way that healthcare is moving. I would suggest this is something we're all going to see over the next few years. Thank you.